get into pancreatic duct stones. So difficult bile duct stones, basic stone management तो आपको सबको पता ही है. Basically it's, you know, it's an extension of that with all these different choices, and we've talked about a lot of these already, but I'll just go over some of them. So generally speaking, the idea is you get access, you do a biliary sphincterotomy, and we've talked about the adequacy of the sphincterotomy, making sure that based on the size of the stones, there's enough room to remove the stones, and then you can use baskets or balloons. Generally speaking, if the balloon is not easily grabbing the stone or retrieving the stone, then you're better off switching to a basket, like we've discussed. But the key is that you have to have a decent sized sphincterotomy. So beyond that, let's just move on. Sphincterotomy ho gayi, stones nahi nikal rahe. What are your choices? So one option is just putting in stents, and the option here, the idea is that stones cannot be removed. You place the stents and you repeat the procedure in a few months. The benefits are that it establishes drainage, it shortens the procedure time, and basically you can avoid, and if you're pushed in situations where you have patient with cholangitis, it's not safe to do a long drawn out procedure, then you just put stents in and you come back. You may not have the equipment like the appropriate basket or the appropriate cholangioscopy system, or you may have the equipment but the person who is most familiar with it and has the expertise may be out. And the idea actually here is that stones can actually be downsized. They can go away sometimes if they're soft sludge stones, or they can basically be broken down by friction against the stents. So it may help with stone removal in the future. And stent placement is also an option for patients who are not considered good candidates for repeated procedures or surgery. So there is the concept of putting stents in elderly patients and just letting them be. Interestingly, that study at the bottom is a Italian study where they felt that the patients weren't. It's an interesting study because they were not candidates for surgery, but they were candidates for repeat ERCP. So the choices were multiple stents and first schedule repeat ERCP or just let the patients be. And the outcomes were better if they changed out the stents every 3 months. But the question becomes, if you're changing them out every 3 months, why not just remove the stones and leave the patients be? So here's a real life example. I had this elderly patient with comorbidities, including cancer, including cardiac disease, who had these multiple stones in the bile duct, presented with cholangitis. So on the index procedure, you can see gallstones too. We did ERCP, sphincterotomy, and put in a couple of stents. Interestingly, during that hospitalization, he was also anticoagulated, so they stopped his anticoagulation, got the gallbladder out. But then we couldn't get him back in because of his cardiac issues. So 6 months later, when he came for his ERCP, I said, be ready for spyglass. And this was our cholangiogram. All the stones had basically just passed, broken down without the need for doing anything. So what was anticipated to be an hour-and-a-half long procedure was over in like 20 minutes. So the stent approach really does work well in certain situations. So if that's not an option, then of course the one we talked about, large balloon dilation or sphincteroplasty. So isme the one thing I would like to point out is the difference between balloon dilation alone without sphincterotomy versus balloon dilation after sphincterotomy. There are two different concepts. They should not be mixed up. So one is endoscopic papillary balloon dilation or sphincteroplasty. The terms are used interchangeably with no sphincterotomy. So here, this is preferred in East Asian countries. The Japanese talk about it a lot. You basically do not cut the sphincter at all. You stretch the papilla, the biliary orifice with a balloon, and you basically remove the stones. In Japanese studies and Korean studies, for some reason, there is no associated pancreatitis. when they did a randomized trial in the United States, there was an increased risk of pancreatitis with this approach, to the point that they actually stopped the study in between, because there was one death related to, or maybe two related to the pancreatitis, so severe pancreatitis. So in Europe and Asia, this approach is not done unless the patient is a poor candidate for sphincterotomy, if they're anticoagulated, liver disease, etc. On the other hand, the approach of endoscopic sphincterotomy plus endoscopic balloon dilation, which is what has been shown in this course as well, and also known as ELBD, or endoscopic large papillary balloon dilation. You can throw a P in there too. So with any of these, the risks are bleeding, pancreatitis, perforation, versus the benefits, stone clearance and recurrence. So these topics we've touched on already in this meeting, but the questions that come up are size and extent of sphincterotomy, size of the balloon, duration of balloon dilation, and pancreatic stent placement. So size of sphincterotomy, the whole idea is to cut it to as much as you possibly can without causing perforation. So that's and bleeding. So the idea is, if you think you've cut enough but you're not sure, maybe you can cut more, stop. Because you can always balloon dilate and then see how things go. There is some thought that and Dr. Sadnaz was discussing this yesterday, that some people believe that you shouldn't cut too much, do a small sphincterotomy and balloon dilate. But my practice, as well as Dr. Saad's and Dr. Khalid Hassan's, is to cut as much as possible and then dilate. The size of the balloon, the general teaching is you size it by based on the size of the duct. So if your distal duct is 15 millimeters, there's no stricture, then you can go ahead and balloon dilate to 15, 18. You can go up to 20 millimeters. Duration of dilation is controversial, so there are some studies that suggest that the longer you dilate, the less likely chance of pancreatitis. So if you do a short dilation, just 30 seconds, you don't have a sustained dilation, and then you get edema and you get pancreatitis. If you keep the balloon up for 2 minutes, 3 minutes, then you can reduce that risk. Generally speaking, again, personal preference is to go for at least 2 minutes. But interestingly, in a meta-analysis, it did show a significant benefit with longer duration. But subsequent studies have also shown that it doesn't really matter. And then pancreatic stent placement, no definitive data, but if you get in and you're worried about pancreatitis, you could. However, if you do a long, large dilation, then you may not need to worry about it. What is the sort of the world community's take on all this? So there's a consensus guideline on this, actually, on large balloon dilation, consisting of 30 studies, 6 randomized trials, and they say that large balloon dilation is an alternative or adjunct to mechanical lithotripsy or difficult stones. Use it with endoscopic sphincterotomy, and limit it to patients without sphincterotomy only when you have a strong contraindication to sphincterotomy, such as anticoagulation. So that's a guideline-based approach to this. Here's an example. You've seen these cases already, but you have a large stone in the very dilated bile duct. Do a sphincterotomy. This could have potentially been extended even more, but then do a large balloon dilation to about 15, 18, and then you have this large dilated CBD. These are the fluoroscopic images, dilation of the balloon, and then using a basket. That's what Dr. Khalid was saying yesterday, that if you get a basket, try not to crush the stone, but just to try and retrieve the stone intact, because then you don't have multiple stones to have to deal with, and that's the stone delivered. So that's the use of large balloon dilation for large stones. Mechanical lithotripsy, this can be done before or after dilation, but generally nowadays we use dilation first. So here's a stone in the bile duct. You get the basket around the stone, and then you gently close it. If you close too fast, it slips off. And you're closing as you're advancing the basket up. So it's closing down and you're pushing up. So it closes around the stone. And then you have the mechanical lithotripter either a crank type lithotripter, or you have the dilating gun that's also used for balloons that can attach to the basket like the trapezoid basket, and you break and fragment the stone, and then those stone fragments can be removed, and then you can also sweep the duct to make sure there aren't any fragments left in there. So that's the principle behind mechanical lithotripsy. There are different types of baskets. There are those baskets that are made only for lithotripsy, and there are those that are made for stone retrieval alone. But the trapezoid and there are some other baskets can function as both. And the other advantage of the trapezoid is that it has that little cap at the top, so that if the stone gets stuck, generally speaking, you should be able to keep cranking the handle and break the basket so that it doesn't literally get stuck in the patient. But one has to be familiar with all these steps before you start using these baskets in big stones. Just quickly moving forward, the next one is electrohydraulic and laser lithotripsy. So when is this indicated? When standard techniques aren't feasible. So you have a rectangular stone, you have an impacted stone, in this case in the hilum, or you have a stricture, which is a surgical stricture. You can see there are clips here, and then you have a stone above that. So in these situations, baskets are not going to work, balloons are not going to work. So the idea is to do cholangioscopy and do lithotripsy. This is a failed mechanical lithotripsy, failed endoscopic large balloon dilation, and the stone just wouldn't come out. So the idea is you go up there with a cholangioscope and you break up the stone. The most commonly available system currently, of course, is the Boston Scientific Spyglass system, the version 2.0 now. And it's a single operator cholangioscope that attaches to the scope, and you have a 10 French catheter that goes into the duct. And then you have now, apart from lithotripsy, you also have snares and baskets that can go through the cholangioscope. They're not cheap. They cost about $500 each, so not necessarily used very commonly. So this is a patient with cholangioscopy assisted balloon electrohydraulic lithotripsy. So the idea here is that you have the 10 French probe in the channel in the duct, and you have this little 2 millimeter probe that goes, or less than 2 millimeter probe, that basically you use saline and you use electric current to generate high frequency pulses in the saline, and that helps fragment the stone. As you can see, this it allows you to see up the duct and do cholangioscopy. Once you've broken the stone, which takes at least a fair amount of time, you can then remove these fragments. A lot of them just fall out on their own, but then you have to remove them. The same here is being done in the patient with above the stricture. This is with the older version, but actually not a bad sort of quality image, but the whole idea being the same thing, that you get in there and you break the stone. This is actually, I think, a laser case with the orange light with the laser. So that's laser or EHL assisted cholangioscopy. So a few other things, if you have a patient with altered anatomy, you can't get to the anastomosis and they have an anastomotic stricture, then if you have percutaneous access, then you can use a flexible bronchoscope or a cholangioscope, come in from the PTC tract, get into the intrahepatics, and then you can work on the stone. So this requires coordination with the interventional radiology group. You have to get a drain in first, leave it for 6 weeks or so to allow the tract to mature, and then you go back in and integrate through the drain, and you can clear out the duct that way. So it's good for altered anatomy patients. Usually it has to be at least a 10 French drain. So, they can go up to 12 French is my understanding.
What I do is I ask them 14 French.
Oh, you go 14?
So
Yeah.
change it after a week or 2 weeks and make it
Upsize it, yeah.
upsize it. This spice scope one, it's 11 French.
Yeah.
So it would not go through 10 French track. The spike, digital spike is 11 French.
Yeah, and I've been a bit aggressive at times. If it's tight at the skin, then I will actually balloon dilate it a bit and then advance the spine through it. So where I was before, the interventional radiology guys weren't very hands-on and they let us do whatever. And my new institution, they like to be really involved and they want to do this themselves, which I'm like, you can have all these cases for all I care, because they're so time-consuming. But they want to be all sterile, and it's just easier to have to work with them, but to let them do their thing, and then when they give me access to go in. But you need at least 11 to 12 French to be able to get. But I'll tell you, the bronchoscope is actually smaller, and you get very high quality visualization, and you can do the EHL probe through there. You only have two-way flexion, you don't have four-way flexion. And then cholecystoscopes you don't really use. Surgeons have those, so they also allow two-way flexion. And then extracorporeal shockwave lithotripsy. So you're basically, blasting it from the outside and allowing the stones to break up. So here's a case of intrahepatic ductal stones that were treated with extracorporeal shockwave lithotripsy, and then the duct was cleared. To be honest, I have never sent a patient for S-wall for biliary stones, but there is a role. It's not easy, exactly. It's not easy to do. So surgery, is there a role? Of course there is. I think there are situations where endoscopic therapy will just not work. And a large stone burden in a patient who needs to have a cholecystectomy, they can always remove the gallbladder and clear the bile duct at the same time. And then recurrent pyogenic cholangitis, also known as previously as oriental cholangitis, there is a role, especially because of the risk of cholangiocarcinoma too. So this is a patient with recurrent pyogenic cholangitis, stones in the left system, dilated left system. And immediately once we knew sort of this was going on, left stents behind for drainage. But then this patient ended up getting surgery and actually had occult cholangiocarcinoma in the duct. So that's basically it in terms of biliary stones. Do you want me to talk about chronic pancreatitis and pancreatic stones quickly? Yes. Okay. So basically chronic pancreatitis is like a syndrome, right? It's not just, stones are just one part of the syndrome, and you have to think of it this way. It's acute, recurrent, progressing to chronic, patients have pain, etc. Most common symptoms, as we all know, pain, but then exocrine insufficiency, as well as endocrine insufficiency. And then localized complications, duct obstruction from stones, strictures, biliary stricture, duodenal stricture, pancreatic, and then duct leakage, pseudocysts, etc. So the principles of management, obviously offending agents need to be stopped, optimized treatable diseases like hypertriglyceridemia, low-fat diet, vitamin supplementation for deficiencies, pain control, at least in the Western world, that's a real issue. I'm not sure how it manifests here and how it's controlled here. Now we've gone from pain control to pain-associated narcotic addiction and dealing with that problem. So it's just you trade one problem for another. Pancreatic enzyme replacement. This is really interesting for me because it can help with pain. The issue is that they are, as you all know, they're pork-derived, right? They're pig-derived enzymes. So the question is, I'm just, of all the patients, Muslim patients who I've offered enzymes to, only one has ever said yes. They all say, no, if they're coming from, if pancreatic enzymes are derived from pigs, then I'm not going to take them. And I don't know if you guys have run into that issue here or not.
I've told my Muslim patients here also in Lahore
Yeah.
that it's something that you would have to pay. So it's medicinal and you have to pay.
Yeah.
If you don't take it, you don't have a choice.
I mean, that's what I try and say, but I say ultimately, if you choose not to take it, I can't force you to take it. It's your choice. So most people just say no. This is okay. Well, it is. I mean, oh yeah. Patients taking, physician doesn't know, so you're just like.
So the crayon is actually porcine. Did you know that?
All of them, Zenpep, Creon, Viocase, all of them are the same.
There are some natural supplements available in the United States,
Yeah,
and but their quantity of pancreatic enzymes in that is really small.
yeah, exactly.
So for recombinant, not going to be.
No.
No, which I don't understand what
All the formulae
versus exactly poor side. So it's always good to know. I mean, if we're giving it here, how much do the patients know and how much the physician? And I'll be honest, if I really had to take it, I would take it. But a lot of people don't want to. So it depends on who you are and what your belief system is. Anyway, so antioxidants, there was that Indian study, which is a randomized trial that seemed to show benefit. I have never seen it work. I still recommend it, but they're usually over the counter, and I'm not sure if that really works. And then endoscopic therapy, if there are choices, and then surgery. That's just like the principles. That's chronic pancreatitis in a single slide, right? But it's more complicated than that. So here's a patient with pancreatic duct stones in the head of the pancreas. You can see up there a lot of calcifications. And they keep extending. If these are different cuts on the CT, and you can see how many stones there are. So this patient basically underwent an ERCP and generally required multiple sort of procedures, but the idea was to do EHL and break up the stone. So here now we have the cholangioscope, rather as a pancreatoscope in the pancreatic duct, and we're inside the pancreas. You see these white calcific stones as opposed to the yellow pigmented stones in the bile duct. Same probe, and we're breaking up the stone fragments, and then you have to keep at it till all the stones are cleared. You can see what's really nice is you can see the side branches of the pancreatic duct too. You can see there's inflammation in the duct related to the pancreatitis. You just keep at it. Here, the main challenges are maintaining your scope position to allow you to continue to break these stone fragments and blast them away. So these are usually an hour plus procedures. They take time. They have to be with general anesthesia. Patients really have to be put out. And then once you've got those fragments broken up, the duct looks nicer. This was a Devisum patient actually. And then you just use baskets, generally speaking, to retrieve these because these are hard calcific stones. So balloons may break. So I tend to use baskets for these ones from the get-go. And if in doubt, I can always use a balloon.
Which basket do you use in pancreas?
I usually use the trapezoid, the 2 centimeter trapezoid. Yeah. And this once I'll use the wire as a guide. But if it looks like it's an easy cannulation, then I'll just go freehand with the trapezoid. As long as it takes the turn. And if it's not taking the turn, then I'll use it over the wire. So basically, then if you're worried about stone fragments causing obstruction, you can always leave pancreatic stents behind. So there's like 2-5 French stents left in the duct. But it's not uncommon for you to require more than one session to clear these. And then this was a patient in whom this one particular stone fragment just did not want to break. I wonder if this video is going to work. But so we ended up trying EHL twice, and then I had to bring her back because we don't have laser in our unit, so I had to set it up in the operating room with the surgeons. And this is now using laser, and laser lithotripsy works. Is more efficacious than EHL, and it just like totally blasted away the stone. Interestingly, the light on the laser is just for guidance. There's no like real laser beam being emitted. It's just it just shows you where it's going to be most effective. And there's the duct upstream, and you can see all these stone fragments at the end of the pancreatic stone lithotripsy. So this was a patient. We can see these stones. She's got a distended stomach with these stones in the pancreas. And I thought this was a reasonable candidate for EHL. You can see the pancreatic duct is dilated upstream. There are stones here. And I just could not get good access. So I had to end up recommending surgery for her. And what they did was basically this is the pancreas. and they've filleted it open, and you have the pancreatic duct in the middle, and then you have a catheter coming through the pancreatic orifice, the dorsal duct. So this is like a Pusto procedure, which I'm sure, do you do those?
We've had a couple of patients
Send.
in AKU, I remember.
Okay.
I haven't seen apart from those two patients.
Oh, okay. But this works well as a drainage procedure. Professor Sajda, do you? This is a Pusto, so basically, yeah, so this is for calcific pancreatitis, basically. So it works well, actually, you know. So the idea is that you do endoscopic therapy if you can, but if you just cannot, stop subjecting the patient to repeat unnecessary procedures and refer them for surgery.
Question here is, we had a couple of patients who had calcification in the pancreas, which was reported as main duct and ductal calcification.
Yeah.
We went in, and when we calibrated the PD, it was okay. It was also dilated with all the stricture, but there was no stone. It was just the parenchyma that was.
With calcifications, yeah.
So how do you differentiate? Do you do a US before to
You-
confirm whether this is a parenchyma or in the duct, or do you
Yeah.
just
So,
rely on the CT?
so I think it depends on the time interval between the CT and your procedure, right? But usually pancreatic stones aren't just going to go away. They need to be extracted. They're not like bile duct stones. Your pancreatic orifice is so small that those stones are not going away if they're truly in the main duct. So if you do your first ERCP and don't find them in the main duct, then that was an error on the part of the radiologist reading the CT. But the general principle is look at the CT images yourself whenever possible to see if it's in the main duct or not. And the other thing is, even though we call them parenchymal stones, all stones are actually in ductal structures. So they're just in peripheral branches of the main pancreatic duct. That's all they are. And some of them may slip out. It's not like they're going to slip out and fall back in, but I think in reality they just form there and stay there because these are such small ducts, and the ones that occur in the main duct are actually forming in the main duct. So in that situation, I think it most likely was a misread on the part of the reading radiologist. So that's why I always encourage my fellows to look at the imaging before you start a case.
We have here in Pakistan somehow young patients with chronic pancreatitis.
Yes.
So many young patients without any obvious cause. Obviously, alcohol is not very.
That's not the cause.
Also, not the biliary. I mean, the cause is not obvious in many of these. Now, these patients have all those features of stones, pancreatic dilation,
Yeah,
and
yeah.
once you do an ERCP and place a stent, what would be the further course of events? I mean, for how long these patients would be like in the exchange of stents or what?
Yeah, so it depends on the underlying cause, right? So a disease. So if you have, so firstly, this is likely genetic, and it used to be called tropical. I think it's the same as what's in India, but I think the nomenclature has changed. It's no longer called tropical. It's called idiopathic recurrent pancreatitis, and they're calling it idiopathic because we don't really know the underlying etiology, but it's genetic. So the idea is we need to figure out the genes. But then the disease management becomes, the big thing with pancreatitis is you manage symptomatic disease. If patients are asymptomatic, you tend to leave them alone. So if they have a stricture that is causing problems, then you balloon dilate, you stent, and you do repeat ERCPs for stenting for up to maybe a year to see if it opens up. The European and American guidelines suggest that if the stricture hasn't opened up, then you should consider surgery. If it's a leak, you stent till the leak is resolved, the pseudocyst is gone. And if it's stones, you basically do ERCP till you can clear the duct. And if it's not feasible, then you consider surgery. So the principles are the same in different parts of the world. The one thing is with younger patients, it's very challenging because obviously you don't want to subject them to surgery too early, but then doing repeated procedures that are not solving the problem isn't the solution either. So it depends on what sort of access you have to surgeons for definitive management, but you have the risk of diabetes and other problems from the surgery. So it's, you know, it would be really nice to be able to actually study the prevalence and incidence of chronic pancreatitis in Pakistan and young patients, which by coming to Pakistan, I'm hearing more about it, but The Indians are obviously studying their patient populations quite a lot. We haven't done that yet, but hopefully, inshallah, in the future we can do that. So, and then with the advances in sort of genetic testing, being able to look and identify the genes that are associated with it. So that is it. This is our university hospital in San Francisco. I don't know if any of you have been there. And then you have the Golden Gate Bridge way in the back there. So, any other questions?
In otherwise, endocarditis, which is recurrent, should we do a prophylactic cholecystectomy?
And it's a big debate subject. Generally speaking, if recurrent acute pancreatitis, which is no obvious cause, there is a recent study in the surgical literature that patients who had empiric cholecystectomies tended to do better than those who did not. So I will recommend, I will do an EUS, look for microlithiasis, little sort of floaters of sludge in the gallbladder or the bile duct. And with that study, I have a low threshold for sending them for a chole, but explaining to them that it may still not solve the problem and they may still continue to have pancreatitis. I think in the scheme of things, it's not that bad a procedure, though, obviously every surgery carries some risk, and bile duct injury is the big one with cholecystectomy. So.
What is the utility of doing a US-guided biopsy of the pancreas in patients who've got chronic pancreatitis? Because like there was a lot of fibrosis.
No, the risk of causing pancreatitis is high enough that you don't typically biopsy the pancreas unless there's a specific reason, like a mass, concern for a mass, or concern of autoimmune pancreatitis. There you think that's where the biopsies help. But if you have chronic pancreatitis, it's idiopathic, you just accept it for being idiopathic, and you can look with EUS, but you would only biopsy if you see something abnormal that is concerning for a tumor. The other thing is EUS is not as good for picking up tumors in the setting of chronic pancreatitis as opposed to normal pancreas. So a patient who has chronic pancreatitis has so many changes, and it can be very dark and abnormal looking, and that can make the ability to pick up subtle tumors more difficult. You don't have to get a tissue diagnosis, right? So if you're worried, do the biopsy. But if it looks mostly like the entire pancreas looks the same, it's more like chronic panc, just let it be. If the patient's clinically doing okay, you just let them be. If you have a concern that, there may be an occult malignancy here that I'm just not picking up, and this area looks more abnormal than the rest of it, you can always biopsy it. Most of the time they don't get pancreatitis, but you have to be wary that you can cause pancreatitis. But there has to be a good indication. You just don't, we're not sure how bad this patient's liver disease is, so let's get a biopsy. We don't do that in the pancreas. So.
This is regarding enzyme supplements.
Mm-hmm.
Prion, for example. Not all chronic pancreatitis people need
Yes.
enzyme supplements. How do you, one is the case Frank ran option.
Right.
These patients obviously need.
Yes.
One is chronic pancreatitis on imaging, but apparently
Yeah, no.
where is the
The line is when they develop symptoms. So pain is controversial because it may not work. The idea is the uncoated enzymes, Viocase, in a study was shown to be beneficial for pain relief. Viocase is the form. Yeah, that's the uncoated one, right? Everything else is coated and theoretically does not work as well. I will still offer it to my patients, and in our system, the insurance will determine which enzyme you will really get. And some will say, I feel much better with it. Others will say, it doesn't make any difference. Can I stop it? I'll say, sure, stop it. But the main one is what you pointed out, maldigestion. So if you are losing weight, you have steatorrhea, you have frequent bowel movements, those are the patients who will benefit the most. Or if they've had a pancreatic surgery, like a Whipple or a distal, and they've developed pancreatic insufficiency, those are the patients. If the patient's eating well, maintaining their weight, there is no steatorrhea, then you don't need to put them on enzymes. You only do it when they present with those
I
manifestations.
usually use stool for fecal elastase,
Right.
and if it is low, then we give them.
But even then, I will give it only if they're losing weight and if they have symptoms, right? So you can use the elastase to look for insufficiency, but you may not necessarily need to treat it because they may not be symptomatic. There's like the teaching classically is that you have to lose 90% of your pancreas function to become maldigested and maldigestive and malabsorptive. So you have to be quite advanced. But those patients have the most dramatic responses. You put them on, they've gained 20 pounds and they feel much better. So, okay.
You said that nowadays people are having problems with pain relief medications, addiction to pain relief narcotics. So we have good modality of EUS through that neurolysis and
It,
they don't work.
no, it doesn't have a lasting response. So if you look at randomized trials, for steroids and for yeah, exactly. So bupivacaine is just for short acting for the day, the 24. Yes, but if you look at the long term, like 3-month follow up, they're both placebo versus treatment arms are the same. So in my practice, generally, I have not used celiac block for chronic pancreatitis. But I don't know. Do you use it? Yeah, I don't do it much. I do.
It's 60% response. Right?
Yeah. But then there's attrition, right? I mean, you also lose your response. We do celiac neurolysis for cancer patients. That I do more of. But I tend not to because I don't want to have those patients keep coming back to me every 6 months. I don't know, but that's okay. Thanks.
Is the Sharia here? Thank you, Mustafa. I'm sorry I wasn't here. I'm sure I missed an excellent talk. There's a very interesting talk that I heard recently at a meeting. It was related to infections from ERCP scopes. And I thought it would be very important before we actually show you how to clean the ERCP scope as to why it's important and what's different in ERCP scope. Okay? So I want to have... Huh? Okay. उसमें नेट पे हैं हम? ये इतना खराब क्यों हो गया? So we are not connected maybe.